The Delta variant. The Indian healthcare system nearly collapsed in April 2021 as reported infections spiked to 400,000 per day and reported deaths to 5,000 per day, with the true numbers probably being 10 times higher. In the 3 months since that time, the Delta variant has taken over the world, now accounting for 73% of global cases and rising. Around the world, from the UK to Indonesia to the US, Delta now dominates, comprising as much as 99% of the virus circulating in those countries. The US CDC, the WHO, and Public Health England are sounding the alarm on Delta. So the question we should ask is, why are epidemiologists alarmed about the Delta variant? In today's video, I'm going to review the latest scientific literature to answer that question. In doing so, I'll address 5 questions. What is the Delta variant? Is it more infectious? Does it cause more severe illness? Are vaccines effective against it? And what does this mean for public health policy? It's everything you need to know about Delta. This is All Things Public Health. I'm Anthony Custer. Let's get started. First, let's quickly define the Delta variant. To understand Delta, we have to understand the coronavirus and how it replicates. The actual SARS-CoV-2 virus is made up of only 4 structural proteins: the membrane and envelope proteins, which make up the outer membrane, the spike protein, which sticks out of the membrane and gives it the distinct coronavirus shape, and the nucleocapsid protein, which coats the viral RNA. And that viral RNA is coiled up inside the protective membrane. RNA is a sequence of nucleotides, and in the case of SARS-CoV-2, there are nearly 30,000 nucleotides. And these nucleotides give instructions for making amino acids when the virus hijacks our cell's machinery. In fact, every 3 nucleotides tell the human cell how to make 1 amino acid. Then, those amino acids form together to make proteins. Altogether, the viral RNA has instructions to build not only those 4 structural proteins which make up a new virus, but also more than 40 other non-structural proteins, which are released into the human cell to do all kinds of things, such as proofread for errors while the virus is replicating, or even suppress your immune response. Each time the virus replicates, there is a chance it makes a mistake, which can result in an amino acid being different from the previous version, or even deleted. Most of the time, these changes are harmful to the virus, but sometimes the virus becomes better at infecting human cells, which in turn makes the virus more transmissible or even more deadly. That's why tracking how the virus changes over time is important. This is done by genomic sequencing. Ever since SARS-CoV-2 was first identified in Wuhan, China, scientists have been sequencing the virus's genome. Basically, a map is created of the amino acids in each sample. Literally millions of genomic sequences have been uploaded to the GISAID database, which is completely searchable. Looking at that database, we see that the Delta variant, or B.1.617.2, was first identified in India in late 2020 and quickly spread across the world. It has notable changes on the spike protein. If you need a primer on what these notations about amino acid mutations mean, check out this video describing the first variant, now known as alpha. I'll put a link to it at the end of this video. In short, a number of these changes to amino acids have been shown in the laboratory to make the virus better at invading human cells and at evading existing immunity. But what evidence do we have of that in the real world? Let's look at research data, including data from the file leaked from the US CDC, and see what the Delta variant is able to do. Maybe a better way to ask the question would be, is Delta more transmissible? The answer to that question is yes. The UK has really detailed data because they do lots of sequencing, so they know which variants are spreading, and they do detailed contact tracing, so they know who infected whom. By doing that, they're able to calculate what's called a secondary attack rate. Basically, it's the percentage of people that get infected as a result of contact with another infected individual. When we look at that data, we see that the secondary attack rate for Delta is substantially higher than Alpha. We see the secondary attack rate is about 12% among households for Delta, meaning if a person is infected with Delta, about 12% of people in the household on average will catch Delta. Compare that to only 8 or 9% for Alpha. That increase seems small, but that actually represents a 30 or 40% increase in transmissibility. So why is Delta more transmissible? It's probably because Delta has substantially higher viral loads. A study of virtually all infected people in Singapore used PCR cycle thresholds as a proxy for viral loads and found that patients with Delta had much more virus in their samples, indicating higher viral loads. To understand what this means, consider the typical COVID-19 test that uses a nasal swab to collect a sample and analyze it using PCR. The number of cycles required to amplify and detect the virus in the sample is known as the cycle threshold, or CT value. If a sample has a lot of virus in it, it requires fewer cycles to detect the virus, so it has a lower CT value. In the Singapore study, the researchers grouped patients by which variant they were infected with, including alpha, beta, delta, and the original wild type. When they compared the CT values among the groups, they found that the CT value in patients with Delta were lower, meaning more virus. Not only that, but it took longer for Delta patients to clear the virus. For the other variants, it took about 14 days for half the people to get a CT value above 30, the point at which it is considered a small viral load. However, for Delta, it was more like 18 days. This indicates that Delta may have a longer viral shedding period. So we see that Delta is more transmissible, which is probably due to a higher viral load and longer viral shedding. But does it make you more sick than other variants? Unfortunately, the answer to this question may also be yes. The Delta variant appears to be more virulent. Data out of Scotland, Ontario, Canada, and Singapore all show a higher risk of hospitalization, ICU admissions, and deaths in patients with Delta. Let's look at the data from Scotland first. From April 1st to June 6th, nearly 20,000 people tested positive in Scotland. Of those, 377 were admitted to hospital. The rate of hospitalization was nearly double for patients with Delta compared to those with Alpha. Using regression, they computed the hazard ratio to be 1.85, which means there was an 85% greater risk for hospitalization among cases with Delta compared to cases with Alpha. Let's look at Ontario. This analysis looked at the 211,000 people who tested positive in Ontario, Canada between February and June 2021, and then categorized those patients into which type of variant they had. The classic version, the alpha, beta, or gamma variants, which all have the N501Y amino acid mutation, and the Delta variant. We see that over that period, that classic COVID hospitalized 4.4% of cases, while the alpha, beta, and gamma variants hospitalized 5.4% of cases, and that Delta hospitalized 6.1% of cases. The percentage of cases that resulted in death looks similar among the groups, but keep in mind that Delta came last, so Delta infections cover a shorter period in the study, and some cases may not have resulted in death during the study period. When these factors are accounted for in the statistical model, they estimate that someone with Delta is more than twice as likely to be hospitalized compared to classic COVID. The authors conclude that these new variants have increased in virulence. And finally, we see the same conclusion in data from Singapore, which is the same study we looked at earlier. There, they found that hospitalizations, oxygen requirements, or death was more associated with patients that had Delta. So Delta seems to be more transmissible with higher viral loads, which may in turn make it more virulent. The next question is, can it evade existing immunity, such as that provided from vaccines? Again, the answer appears to be yes. Several studies have shown that vaccines are increasingly less effective at preventing infection to the Delta variant. The first study, out of the UK, looked at 19,000 people who tested positive and categorized them as infected with Alpha or with Delta. Then, they looked at vaccination status and whether they had the Pfizer vaccine or AstraZeneca vaccine. Computing vaccine effectiveness, they found that a full Pfizer vaccination had a 93.7% effectiveness at preventing symptomatic infection against Alpha, but 88% against Delta. Similarly, the effectiveness for a full 2-dose vaccination with AstraZeneca dropped from 74.5% with Alpha down to 67% with Delta. In another study, data collected on breakthrough infections among healthcare workers in Mumbai, India, showed a similar pattern. The data showed Delta is 10 to 40% more transmissible and can evade immune protection by 20 to 55%. There is data from Scotland, Qatar, and Singapore that showed the same trend of reduced vaccine effectiveness against Delta. Finally, one case study from the U.S. state of Massachusetts shows virtually no difference in outcomes as a result of vaccination status. In this outbreak of COVID-19 in Barnstable County, Massachusetts, 469 cases were identified among Massachusetts residents. Among those cases, 74% of the infected were fully vaccinated. This compares to a local vaccination rate of 69%. Using the CDC's method for estimating vaccine effectiveness from observational data like this, we see that if 70% of the population is vaccinated and 70% of the cases were vaccinated, that is equivalent to a 0% vaccine effectiveness. Hospitalization rates were also equivalent between the groups. And no surprise, genomic sequencing of these cases found that Delta was causing it. Another worrying data point from the Barnstable County event was that CT values, which again are a proxy for viral load, were equivalent between the vaccinated and unvaccinated cases, showing no difference in viral load from vaccination. There are caveats to this data. It is observational and not the equivalent of a randomized controlled trial. There are almost certainly some behavioral and demographic differences between the vaccinated and unvaccinated groups. Nevertheless, it shows the power of Delta to evade existing immunity. So overall, we see that vaccines have lower effectiveness against preventing infection, but they can still substantially reduce the chance of severe disease or death. For example, in the Singapore study, all patients that were vaccinated but still became infected had only mild disease. In the larger Scotland study, we see that if you're unvaccinated, Delta increased the risk of hospitalization by 82% compared to Alpha. However, once fully vaccinated and waiting 28 days for the immunity to take effect, the risk of hospitalization dropped by 72% among those infected with Alpha. The risk of hospitalization increased from Delta even if fully vaccinated, but this is still a big reduction in risk relative to not being vaccinated. For another example, we can see the UK. There, where about 57% of the population is fully vaccinated, we see that Delta still spread rapidly and led to a peak of 45,000 infections per day, almost matching the January-February peak. Nevertheless, death rates are way below the earlier peaks and will probably only rise to around 150 to 200 deaths per day in late August, a fraction of the more than 1,000 deaths per day seen in January and February. As we can see, Delta is more transmissible, which is likely due to a higher viral load and longer viral shedding. Delta is potentially more virulent, leading to higher rates of hospitalizations and deaths, especially among the unvaccinated. And vaccines are less effective against Delta. Breakthrough infections occur among the vaccinated, and vaccinated individuals are able to infect others. However, vaccines do help substantially reduce the likelihood you'll end up in the hospital or die. We can make 3 conclusions from these findings. First, COVID is here to stay. This virus will continue to circulate, and more variants are on the way. Currently, the different parts of the world are dominated by different variants. Delta has displaced Alpha across Europe and much of Asia, Beta is in Southern Africa, and Eta is in Northern Africa. In South America, the eastern half has Gamma, while the western half has Lambda. Lambda is notable due to its high death rate. Peru, where Lambda dominates, has the highest per capita death rate in the world by a long margin. It also has the world's highest rate of excess mortality. Looking ahead, the next big story might be a new variant that has emerged in Colombia and is already spreading in the Caribbean islands and Mexico. Currently called 21H, this may one day be the new Mu variant. This variant is notable because it combines some of the most consequential mutations found in other variants like Delta and Gamma. Second, non-pharmaceutical interventions, or NPIs, are still needed. The age-old methods of wearing masks and limiting the numbers of people in crowded spaces are still needed, especially in areas where vaccination rates are low. In many parts of the world where vaccines have still not become widely available, the introduction of the highly transmissible Delta variant is very bad news. Southeast Asia, including my home country of Thailand, where vaccines remain scarce, seems completely unable to stop the spread of Delta. And third, we can't keep the virus out, but we can limit its death rate. Australia, China, and New Zealand remain the largest countries that still believe they can isolate themselves from the virus. China is continuing with its strategy of locking down cities and mass testing millions of residents. However, it is unclear whether this strategy can remain viable in the long term against Delta. Instead, these countries may have to learn to live with the virus and instead focus on using vaccines and non-pharmaceutical interventions to limit the severity of disease and resulting burden on the health system. In summary, Delta is forcing countries around the world to rethink their COVID strategy. That's it for today. Thanks for watching, and be sure to check out this video that describes amino acid mutation notation, or another video that you might like.